Hello, everyone, and welcome to today's Exploring Obesity Disparities in Marginalized Groups webinar. I'm Joseph Gasparo. I'm CEO and the co-founder of the Center for Healthcare Innovation. Our organization is a 501c3 nonprofit research and education institute dedicated to addressing health equity and health disparities. I'm delighted to welcome everyone to today's conversation, which is part two of a three-part series. The series itself explores obesity disparities, how the disease disproportionately impacts marginalized groups, and culminates with a steps for building healthier communities in our third part of the program in August. So we thank everyone for joining us today for this program, which really explores the root cause of obesity disparities in Black, Brown, and other marginalized communities throughout the U.S. Obesity, as you may know, is a serious disease that impacts millions of Americans. Just some quick data points to provide. According to the CDC, prevalence of obesity increased from 30.5% to 42.4% from 1999 to 2009. As we all know, obesity can lead to many other chronic diseases such as diabetes, hypertension, heart disease. More than 100 million Americans, nearly half of all U.S. adults, suffer from diabetes, pre-diabetes, while 1 in 3 U.S. children born after 2000 is unfortunately expected to develop type 2 diabetes. And like most chronic conditions in the U.S., unfortunately, obesity disproportionately impacts marginalized communities of color and other marginalized groups. Some quick data points: African Americans had the highest age-adjusted prevalence of obesity at 49.6%, followed by Hispanics at 44.8%, and whites at just 42.2%. So we're honored to really convene such an esteemed group of expert panelists to discuss these important issues. And before we get started and we open up the panel, just a few quick housekeeping items to go through. First, we'd like to thank today's partner in the webinar, Novo Nordisk, which is a leading global healthcare company with the purpose of driving change to defeat diabetes and other serious chronic conditions such as obesity. And so we thank Novo Nordisk for their support today. Next, all attendees are automatically muted here. Second, we will distribute the recording after today's webinar, and we'd encourage you to circulate it to others in your network that are interested in the topic. And most importantly, we want to hear from you all today. Please submit your questions to our panelists throughout the webinar. And you can do that by expanding the questions tab on your GoToWebinar control panel and type your question directly into the text box. We usually aim to get to audience Q&A about 35 minutes or 40 minutes past the hour, just to allow ample time to hear from you all. And so with that, I'm thrilled to jump right into the discussion. I'm pleased to welcome to the panel Dr. Ricardo Correa, Dr. Sean Lucan, and Dr. Uzoma Okiagu. And as we go through the questions, if I could ask each of you to provide your title and organization when we come around to you for the first time. And I'm going to start the first question, and maybe we'll direct this to you, Dr. Correa. How do policies and institutional practices contribute to the disproportionate growth of obesity disparities among racial and ethnic groups?
Yeah, thank you so much, Joseph. First of all, thank you for the invitation. Thank you for having me in this panel with this amount of expertise that is here. My name is Ricardo Correa. I am an endocrinologist by training. I am located at the University of Arizona College of Medicine in Phoenix, and a lot of my focus is on healthcare disparities, mainly on diabetes and obesity in Latinx communities, but also on all of the underrepresented minorities. So this is a very interesting questions on how structural policies that are in the healthcare system affect the growing of obesity in the population. So one of the things is that definitely there is knowledge and data about stigma and bias in patients that suffer obesity when they care to healthcare system. One of them is that we know that patients that that suffer from obesity are less prone to have an insurance that cover them for any other medical conditions, that they are less prone to be seen by a provider because of the excess of weight, and also that there is some unconscious implicit bias in the providers to blame obesity for everything that is happening in the life of the patient. So they come, and if you have in my case, low testosterone, it's because of your obesity. Because it's because of your obesity. So all of this start creating a systemic discriminations in the system that start from when the patient arrive, where they don't have in a good chairs, they don't have the equipment when you enter to the room for patients that have a certain weight, to the point that they don't have also, for example, things that we use to measure muscle and fat mass, that is densitometries that allow certain weight. So the entire healthcare system, yes, we don't want to say it, but there is a systemic discrimination that is happening and that we need to fix. And definitely this set of discussion and just talking more and more is something that that need to be done more. The other part of all if we think about the healthcare system is the coverage for medication for obesity. Still, people think that obesity is a cosmetic problem, and that's one of the reasons that you don't see that medications that helps, that have been proven, that has evidence in the sense of helping patients that suffer from obesity, are being approved by the insurance, and then are very expensive if you don't have the coverage for the insurance. So we need to move that needle of thinking about, one, that obesity is a cosmetic problem. Second, that obesity is an acute disease. It's not an acute disease, it's a chronic disease. We should treat it like diabetes for the rest of the life. Even though we have done certain things on a national level, for example, the American Medical Association declared obesity as a disease in 2013, and it's almost 10 years ago, we're still facing the same burden in the healthcare system. In practice, we don't have enough obesity providers that have specialized, or enough settings that are friendly and without less stigma and bias for patients. So a lot more things to do, but I just want to also be the positive side. There are organizations that are doing this. There is this Obesity Coalition that have been advocating at the level of Washington and at the level of different states for this. In Latinos, we have a LULAC that has been advocating for that. We have been seeing a shift, but still there's a lot of more things that individually and that as a society we need to do to make aware of the problem to the people that make the decisions, and to decrease the burden and stigma that it causes in the healthcare system.
Thank you, Dr. Craig. Dr. Lucan, we'd love to hear what you're seeing from your vantage point.
Yeah, well, thanks again so much for having me and convening this panel. And I want to thank Dr. Correa for the comments, many of which I'd like to follow up on. I thought they were, super helpful and reflect what I have seen in practice. So I've been a family doc, public health researcher and epidemiologist, practicing for the last 15 years. Only recently I made a transition from academic family medicine to the world of corporate healthcare and prevention, lifestyle medicine. But in all of those settings and all of those regards, obesity and related conditions have been sort of at the forefront, and it's inescapable to recognize the disparities on full display, both in clinical settings and in the broader community. Just to follow up on some of the points Dr. Correa made, I think the stigma issue and the bias issue and the problem of clinical care is a real one. The perception of a cosmetic issue versus a chronic disease, the issues with medication coverage. When I was doing primary care, I often was having to prescribe medications that were for other conditions, kind of off-label, to address issues related to obesity and related metabolic dysfunction. And Dr. Zomo's on, from Novo Nordisk, who I understand has also helped support this talk. And I think some of the Novo Nordisk products have really been at the forefront. One in particular, I believe they're the makers of semaglutide, which is sort of revolutionizing the obesity care and medications of that ilk. And then more promising agents on the horizon, like the GLP-1 and GIP, dual sort of twin cretin mechanism. But that said, I don't want to get too much into the clinical aspects of treating disease or what's recognized. I think what I bring to the panel is more of a environmental or contextual focus. So as mentioned, I've been a public health researcher, and for the last 15 years have devoted my career to looking at neighborhood influences of food choice and what that means for obesity and chronic diseases. And so particularly looking at foods available, foods available and the food messages. So what the marketing is, what the advertising is, what the signals are to consume, and then what the opportunities are based on what's in neighborhoods. And there are just the starkest disparities you can imagine as you go from one community to another in terms of what kinds of foods are available for people to consume, what kind of messages they're getting to consume them, where the opportunities are, and how that difference varies from one community to another. And so perhaps it's no surprise, sort of in line with some of the disparities that we see clinically, that marginalized groups or groups disproportionately affected are those where there's the greatest amount of availability, there's the most food in sort of non-intuitive places, and the most food that's sort of marketed and pushed on people who sort of need it the least. And I think all of those things contribute to a situation where you can talk yourself blue in the face in an exam room when you have 15 minutes with a patient trying to manage chronic conditions, but after they leave the exam room, they then have to go out and sort of navigate the world in real time with all that intervening all that intervening time between the next time they see you. And so as impactful as you can be in a 15 or 30 minute visit, the rest of the time they're out in the world trying to make sense of it and figure things out and implement the good advice. And even the best motivated, most educated, person who is, dedicated to the idea of doing better will face obstacles and will face barriers over which they have no control and will, can impede their progress. And that's sort of unfairly distributed in a way that, again, the people who need it the most are sort of also challenged the most.
Certainly. And food availability is a huge challenge here in Chicago, unlike, similar to many cities around the country where we take things for granted, such as being able to access, fresh food and vegetables, or even walkability of neighborhoods. I'd like to move on to our next question, throwing this out. Maybe we'll start with you, Dr. Okegu. We've talked about some of the institutional policies and practices, but what do you see as some of the other large obstacles, whether it's policy or education, in really addressing obesity disparities within underserved communities?
Yeah, thanks, Joe, and thank you to both Dr. Correa and Dr. Lucan for the insights that they provided on the first question. So, as Joe mentioned, my name is Uzoma Okegu. I'm a PharmD by training and clinical pharmacist by training, and I currently specialize. I'm a obesity medical liaison for Novo Nordisk. As Dr. Lucan mentioned, we are on the forefront of developing therapy and treatment for patients with obesity who have been suffering from this chronic condition for such a long time. And so I think one of the biggest obstacles in addressing disparities in this patient population, in minority patient population, is provider empathy and understanding. And Dr. Correa and Lucan both touched on this on the first question. I think these disparities will not begin to be addressed unless we are more aware of their existence and admit their existence and the impact that they're having on the communities. And I think that comes through educating both providers and the general population and bringing awareness to policymakers and healthcare providers as well.
Thank you. Anything to add on that, Dr. Correa or Dr. Lucan? So let's talk about, you talked a little bit about education. What are some current challenges for educators and healthcare professionals in addressing obesity within marginalized communities? So I guess challenges both for healthcare providers and then educational challenges for trying to convey that information to the community.
I think that one of the biggest obstacles in addressing these disparities for healthcare providers is many minority groups have distrust in our medical system, and for good reason. When you look at our country's history, there's some shady some medical practices that could have led to that distrust. So there's actually research that shows that 2/3 of minority populations state that they feel that healthcare systems treat them unfairly. Um, about half skip appointments or follow-ups, saying that they stopped seeking care because they didn't feel understood. And as I mentioned, one in three don't participate in clinical trials or get vaccinated due to lack of trust. So that can really provide a large barrier to healthcare providers when they are trying to do the right thing, treating this patient population. And so I think we'll touch on this a bit in the further program, but I think there's some steps that we need to take to kind of rebuild that trust, to break down those barriers and break down those obstacles, so that we can have effective communication, effective treatment for these patients.
Dr. Correa, I see you shaking your head. Please, welcome to chime in.
Yeah, so sorry, I totally agree with Dr. Okago. There is certain things that whenever as a provider we have to address this in different type of population, we need to be aware. And one of the things that because I deal a lot with a Latinx community, is how to address in a cultural way. It's not just in a language way.
Right.
Many people focus on a language way, that, oh yeah, let's do the translation and we have a translator there. But more than translation and in a different language, is a cultural way of addressing the different variety that in the Latinx community exists. So let me tell you an example. One of the programs that we start in when I was in Rhode Island was to address some issues in preventing progression from prediabetes to diabetes, but addressing health, lifestyle modification with diet. Mm-hmm. And then I was focusing a lot there on rice, because rice is the base of the Hispanic population that was living in Rhode Island. They were more from Dominican Republic, they were more from Puerto Rico, from the Caribbean, where rice is the base. Then I come to Phoenix and I continue the same program, and I was talking to the patients, and the patients were like, yeah, I'm eating very healthy, because all the pictures that I was showing to them have rice. But they don't use rice as the base of the meal. They use tortillas, they use corn. So yes, when they were looking at this, they say, oh, I'm eating healthy. But when you start digging and then start understanding the culture that here is more Mexicans and Central American, then you understand that you have to adapt yourself and educate the population. So just this is a quick example in something related with diet, but this can translate to everything that we do through obesity, from the stigma that already the population have, to the issues that there's a mistrust in the healthcare system, as it was mentioned, to knowing that the Black and brown communities are located in places where they have less access to resources, less access to medical resources, but less access to, when we talk about in 15 minutes about have a healthy lifestyle and do exercise, and you don't address that in the community that person live, they don't have green because they live in an industrial place, or the criminalization is very high and they cannot go and walk because something can happen. And if you don't address that issues, then the problem will continue. So we have to, wherever we practice, we have to understand the settings where we are. So when we address this kind of chronic conditions, we need to provide them with resources that are very good for them. Another example that I can give is a food bank. Many of my patients use food bank. But if you look at one time I say, like, hey, can you tell me what it comes in that box? And you see, like, I don't know, 15,000 grams of carbs. And I was like, oh, if this patient is diabetic and has suffered from obesity, why they are giving a box that have 15,000 grams of carbs? Why we cannot address that? And then I offered to my local food bank to say, I can volunteer and adjust a little bit of the box for patients that comes with this diagnosis. They say no. They say that the federal government make it money for quantity and not quality. You know how hard is to hear that from a person that can change the life of another, but they just care about quantity and producing. And of course, high carbs meals are cheaper and it's easier. So addressing these kind of things at a local level, at a national level, it's important. And the last thing that I want to mention is trying to teach the community on how they can get fresh food if even they cannot access it. So the teaching of how to culture that in your own backyard, to having a fresh market from the community, each one is divided. So things like that is education that we need to provide, because the solution is complex and the problem is big, and we are just addressing this 5 minutes or 15 minutes in a clinic, that we are really not addressing anything. We are just trying to continue the thing. So we need to understand the first thing that I can say to the healthcare workers and providers is try to understand your community and be an advocate for that community, to find ways where you can find simple solutions. And also on top of this, I want to mention, sorry that I'm talking too much, of what I want to mention, climate change. So climate change has affected a lot of the Black and brown communities. And this is being translated to increased prevalence of obesity, because where they are located, there is places where there is less fresh food and more preservative food, and this increased the problem. So if also we don't address climate change as part of that social determinant of health in our visit, then we are still missing one of the issues.
Thank you, Dr. Chris. Dr. Lucan, Dr. Okagu, anything to add?
I would just say there's so many great comments, both by, and I want to apologize to Dr. Okagu. My Zoom orientation was set up so I was saying his first name. I didn't mean any disrespect. But so many great points from both Dr. Correa and Dr. Okagu. I'll say, just to dovetail on Dr. Correa's points, about sort of cultural issues and cultural competency. I think that's a huge issue, particularly in some of the communities where I've practiced. I was in the Bronx for many years in a federally qualified health center, predominantly lower income Caribbean Americans. And so, a lot of Jamaican, some Haitian, some other Caribbean islands mostly. And I think, those kind of food traditions and cooking ways don't necessarily align with like a standard recommendation for like a Mediterranean diet, right? I mean, you give this sort of like, global advice that's sort of been, vetted and since, put out there as sort of the standard, but you want to make sure that you can translate that into a way that's meaningful for people and isn't based on like, unfamiliar foods or, cooking techniques or, recipes with which they're not familiar and could adapt, very reasonably and very healthfully into their own, native traditional food ways. I think Dr. Correa also mentioned opportunities for, touched on climate change and also mentioned opportunities for growing food. I think that's huge. I think, the more we can create connection to the foods that people eat and let them know where it's come from. I had done some work, just sort of doing interviews in the community to understand the influences of people's food decisions and food behaviors among a variety of community residents. And we sort of broke out the data by gender and age and sort of seniority. And one thing that was striking in terms of sort of generational issues is that, the old heads, the folks who often came from like Southern traditions of, farming and gardening, had very strong food knowledge about producing their own food, whereas like the newer, younger generation was all about, convenience and, pre-prepared foods, and had lost like cooking skills and lost gardening skills and didn't have the knowledge base to produce their own food. And so I think that's a very meaningful driver of what people choose to eat, or what kinds of foods they tend to adapt and become habituated to. I think related to that is a point I wanted to come back to that Dr. Okagu made about mistrust and misinformation, which I think are sort of global problems beyond what we're discussing today, but just sort of broader issues in medicine and in society. And I think some of that relevant to this conversation comes very deliberately from food companies, who have a profit motive for, putting out like highly processed, refined, not so nutritious food-like substances in the name of like actually in the place of actual nourishing sustenance. And I think when, companies create sort of a place of, reliance where, a younger generation is almost dependent on these, ready to eat, prepackaged, convenient items, and are sort of divorced from the old traditional food ways and food producing and, farming techniques. I think that starts to set up a real problem or a real unhealthy kind of trend in, overall dietary pattern. And there's more we can say about that. I don't want to monopolize the discussion, but I just thought, it was great points by both Dr. Okagu and Correa.
Thank you. We talked a little bit about food availability, and so some communities have been fortunate enough to receive interventions that are directly address the factors that lead to obesity. We've seen things such as subsidized farmers markets, school-based exercise programs, or educational classes to increase knowledge of consuming nutritional sustenance. How can we ensure that every community has access to some of these resources? And are there any ways that we, as healthcare professionals, can increase participation in such interventions?
Well, I'll jump in, and again, I don't want to monopolize, but I've done some work, or at least have some experience in this area, and I think there is an interface. I mean, it's sort of the the coupling of clinical medicine and public health, right? And I think there are opportunities to pull on both levers to kind of move people towards healthier behaviors. So from the clinical standpoint, what doctors can do. I mean, certainly you can be an advocate in your patients' communities to help improve the foods. It sounds like Dr. Correa did some work with a food bank and, was volunteering and was, perfectly willing to help improve the offerings there. And that's, very noble work, but, unfortunately not very common. Other things that have been proposed and tried and actually have occurred, with some frequency are things like fruit and vegetable prescription programs or food voucher programs where you can actually, send a message in the form of a prescription to a patient about how important this is, right? I mean, it's, just like I would write for a medication or write for any other medical supply. I'm going to put this down on paper in doctor signature saying like, you should eat, this many fruits and vegetables. And in some cases, those prescriptions can be used as a coupon or a voucher or a subsidy to bring to a local farmer's market, to a local food bank, to even a local bodega. And then that gets into the public health aspect of it, right? The community neighborhood involvement where you can work with those groups. So like, in the Bronx, so a bodega, for those that don't know, it's not a term necessarily that's used. It's just a small store, small community store. And most of those small store owners come from the communities themselves. I mean, they are residents of the community. They care about the community. They're not invested in making people unhealthy. They do want to make a profit, but if you can show them that there's demand out there for healthy food and help create ways for them to stock it, and also make sure that they have a steady stream of customers coming in demanding, apples, oranges, bananas instead of like, chips, cookies, and soda, like I think that can be a win, right? And that's just one kind of example of the interface between clinical medicine and public health and community advocacy that can drive things in a healthy direction.
Thank you.
And
Dr. Please, yes, Dr. Correa, please.
Sorry, Joseph. So I want to add to Dr. Lucan. I think that what he mentioned is perfect. It's the perfect interaction between clinical medicine and public health. And one of the things that have been seen that helps a lot in our communities is using our community healthcare workers, or however you want to call them. In Spanish, we call them navegantes, proveedores de salud, whatever you want to call them, but using them as a source for the community, because really the community trusts them. These are leaders in that community. These are people that are back and forth from the clinical to the community. They understand different things, and using them as a source for education and as a source of finding opportunities where they can get together. For example, in one of our programs, we bring those community healthcare workers with the community so they can start having like cooking classes. It's not a chef, the person that comes. It's one of person of the community that want to help, and then just show how to have a cooking of a salad and how to use the resources that they have in that community in a healthy way. So I think that obesity management is multidisciplinary. This is not the responsibility of just the provider. It's the responsibility of the entire healthcare team. And using community healthcare workers has demonstrated to change a lot of the things.
That's a great point. We have some exemplary programs here in Chicago, and I've seen some of the evidence-backed data around the leverage of community health workers to make inroads in the communities where these community health workers live and work in. So that's a great insight. Moving on to our next question, I'll direct this question your way, Dr. Okagu. Is what are some of the responsibilities of the various stakeholders, whether it be policymakers or community leaders or healthcare professionals, when really taking meaningful steps to address obesity disparities?
Yeah, I think some meaningful steps that we can take. So our responsibility, once again, we've all touched on it several times today, is continuing to bring awareness and education to the issue and not pretending that it doesn't exist. So taking time to understand the patients, as everybody has mentioned, and showing empathy is very important as well. When we are having these discussions with our patients, we want to make sure that we're avoiding using stigmatizing or blaming words. Dr. Carrera mentioned that earlier, because these words can be perceived negatively and maybe discourage patients from wanting to continue to seek additional help. So using patient-first language to distinguish the patient from their condition will make the patient feel more empowered. And also being mindful of how and when you're discussing their weight. So really having cultural competency to know how to discuss the weight with this specific individual. So asking how you can talk about their weight, how they feel about their weight, and what words they prefer to use when we're discussing their weight. And then just being an example, educating and informing, and being an example when discussing disease. So people around you can learn, listen and learn from you, and kind of carry on your example as well.
Great. You talked a little bit about stigma. Let's dive into that a little bit more before we open it up to audience questions. So what are some of when we think about stigma, what are some of the most critical challenges or steps that we must take if we really want to address the underlying factors that perpetuate these stigmas that are associated with chronic diseases?
Yeah, I think we can take some steps to kind of transform our clinical practice to make our patients more comfortable. And I think, once again, Dr. Lucan and Dr. Pereira touched on this as well. But doing things such as hiring clinical and office staff who are more culturally competent and linguistically representative of the patient population that's being treated will make the patient feel more comfortable when they're coming in for their treatment. Doing things like marketing or advertising the diversity of the office so that they feel comfortable as well will help as well. And then doing things like self-assessment. So using periodic self-assessments with your patients to ask, how comfortable they're feeling, if there's anything that they feel that needs to be changed, so that the patient really feels seen and heard, and that we're not using a one-size-fit-all approach when treating these different patients. Because, as mentioned, we cannot just generalize treatment, dietary recommendations and treatment recommendations on all patients, because we're all coming from different backgrounds, different socioeconomic situations, which makes it difficult to use that generalized treatment recommendation. So I think some of those steps will help to transform the clinical practice and hopefully eliminate some of these disparities.
Dr. Lucan, Dr. Correa, any thoughts on how do we break down these stigmas?
I just want to say I think all those points are completely valid, and I agree 100%. Just to add on to the point about person first language, which I thought was such a great one. I mean, that's something that I've really been trying to prioritize in my own organization, because I think it's so embedded in even in very high quality medical contexts where you have the patient's best interest in heart. I think it's very easy to resort back to language that is not helpful or constructive or productive, and can work not only to your disadvantage as a provider in terms of motivating change, but also be really sort of frustrating to the patients and limit their be very stigmatizing. And so like a good example is saying the obese patient, right? Which like sort of defines a person by their condition, as opposed to as Dr. Akagu said, put the patient first. So the patient with obesity, or the patient having obesity, or the patient who's been struggling with obesity. And I think just changing that framing, language is important. It shapes people's ideas and thinking, and how we perceive the world and how we understand it. Can help people move away from defining individuals by their condition, and help recognize them as a person who has not a cosmetic problem of deficient willpower, but a chronic disease that's actually complex and requires sort of multi-component attention. So we actually do a test in our offices as sort of an assessment of cardiorespiratory fitness. And prior to, I should say earlier, sort of pre-test considerations had included a certain level of body weight as an exclusion criteria for the test. And I think that was mostly not based on evidence, but based on the presumption that if someone is carrying too much weight, that they're inherently unhealthy, or a threat to themselves, or dangerous. And it was, I did a lot of work to say, well, no, this is a presumption, this is a bias, this is not based in evidence. People can be carrying extra body weight and be perfectly fit and are perfectly able to conduct this test safely. And we should not be, stigmatizing people, or, sending people a message that, we think that they're of, they're not equally able to do this test because of some body characteristic. And so, I think that's a struggle, because I mean, in medicine, we do it all the time. We say like the diabetic in room 4, or the hemophiliac, right? So it's hard to move past that, just among ourselves and communication with colleagues. I think, part of it's historical, and part of it's in terms of efficiency, and part of it is just, how things have always been done. But, just because that's the way things have always been doesn't mean we don't need to move beyond that, and really sort of, challenge the way we talk about people, we think about people, we include people, and, make an environment that's inclusive and welcoming of all.
Thank you so much. We're going to switch gears. We have just a lot of great audience questions come in. So for the last 15 or 20 minutes, we'll cover these audience questions. First question is a great question. Thank you for this great panel. The discussion has centered a lot around communities and understanding the unique challenges or barriers that different communities face. So how do we as healthcare professionals listen better?
I can start. I think that this is a great question, and this is where the intersect of being a healthcare professional and being a leader is there, because understanding the community and understanding the problems is something that we can do. But if we just understand, we are not doing anything. Then we have to take the next step. It's trying to find solutions that are probably local, that can be addressed with the community, but also finding solutions with our local governments. Sometimes you can go to the city, and the city can provide you a lot of resources that probably the community didn't know, because sometimes cities are not very well in disseminating information. So sometimes you have to get it a little bit higher than this. And I think that that's very important, that we that are involved in healthcare, we are not just a person that see patients, but also we have inherit another role, that is being an advocate. And then that advocacy is important. I know that not everybody have the skills, but there are ways to learn, and that's a way that you can change your community. And just to piggyback our last question about stigma in the, I think that something that we have to address as now, yes, as a healthcare workers and provider community, is the big stigma that exists in obesity in the entire society. If you look at the big banners, if you look at the media, what is that they are trying to sell you? They are trying to sell you that thin is the standard. And we know that there are many thin people that suffer a lot of heart of cardiovascular outcomes, and there are people that have different that suffer from obesity that are more protected. So trying to deal with that big elephant. I know that this is not the time, but for this, but I feel sometimes so frustrated, for example, with the cloth industry, where they sell that this model of thing that is just frustrating to the person that suffer from obesity, and then causing more mental health problems. And it's our society the ones that is causing that. So I just wanted to add that part.
Thank you. Our next question. We know that obesity is underdiagnosed, undercoded with medical providers, and must be recognized in the claims data for payers and employers to realize obesity is actually a disease. What are some things we can do to help address this with employers and our state Medicaid plans to help cover medication management of obesity?
Yeah, I think that's a great question, and it's something that it's a fight that we are fighting on a daily basis at Novo Nordisk. And one of the ways that you can approach payers and insurance companies is by just showing them cost analysis data on the different types of comorbidities that are affected by obesity. So with some of these companies, money talks. So if they see obesity as something that is just an issue of vanity, they're not going to want to cover the medications that will help to treat this condition because they don't see it as a medical condition that is really affecting patients. But if they are not going to see obesity as a disease, you can show them things such as hypertension, diabetes, osteoarthritis, depression, and all of these different types of conditions that are exacerbated in patients with obesity. And you can show, cost savings, long-term cost savings that many of these patients will have because they won't need to be on an antihypertensive, they won't need to be on a statin, they won't need to be on any antidepressant medications or medications to treat their osteoarthritis as well. So approaching it from that angle, I think is one of the best ways to have these discussions with the insurance companies. And once again, we do have to continue to drive home the fact that obesity is a chronic disease, and showing long-term data of some of the cardiovascular outcomes, et cetera, that patients with obesity encounter if it is not treated early and often.
Thank you. Our next question. Childhood obesity is a significant contributor to obesity. What can be done to reach mothers raising children to prevent childhood obesity?
Sorry, what was the question? What could be done?
What can be done to reach mothers raising children to prevent childhood obesity?
Well, so I guess I can jump in. I mean, I think it's a challenging, it's a great question and a challenging question. And I think if I or any of the other panelists had the answer to that, the world would be a much happier place. Because, as has been emphasized, I think, during this panel multiple times, obesity is not a simple issue at all, or a simple cosmetic issue. It is a chronic disease, and a multi-component chronic disease that has multiple inputs, not excluding, things that happen in terms of imprinting and, sort of genetic predisposition before a child is even born, and other exposures that happen in utero, and then sort of how they're set up for moving forward, once they enter the world. And then once that happens, and moms have control again, it gets back to the point about obesity is not a deficit of willpower or a lack of personal control, and it's about managing sort of the cards you've been dealt, and those cards are not sort of fairly distributed, and in certain communities the chips are sort of stacked against you. And so helping mothers, helping patients, helping all of us as a society kind of figure that out is a complex problem. I don't know that there's a single answer or a single piece of advice. I mean, the standard kind of like get them exercising more and make sure they're eating well falls a little bit flat when like there are all the barriers in the way of making that happen, not least of which is knowledge, and also contributed by sort of the environmental context that constrains it. But I do think just going back 2 questions, I think one of the viewers or attendees asked about listening, and I think that's the key point, right? So not everyone is different. It's not a rubber stamp approach. Like individuals are unique and their situations are distinct, and we need to listen to our patients. And so, a 15-minute visit doesn't necessarily accommodate that very well. And that's just sort of a deficiency of our healthcare system, which is unfortunate among its many liabilities. But, also in terms of listening, there might be more systematic approaches that could be applied, like, a standard screener that's given to all patients, or some kind of community health survey, or some other way to try to get a sense or a finger on the pulse of what's happening in a way that moves beyond that one patient and that one interaction, in a situation where, that individual might not even have awareness or might not even, fully recognize all the challenges being faced. But I do think listening is critical because each circumstance is unique, and we have to kind of figure out how to help people succeed in those kind of unique circumstances.
And I want to just add a little bit to Dr. Lucan, because it's so important. This is a complex answer. There is no straightforward answer, but something that for example is again going back to understanding the culture of the person. A lot of the culture in the Latino culture is that you are healthy if you have certain if a kid have certain amount of body fat. So the grandmas or abuelitas will, when you go to their house and they see that, oh, probably you are a little bit thin, they will just give you more food because they think that you are unhealthy. So that culture is imprinted in everybody. So they want you to have to be certain amount when you're a kid, and we know that translation of kid suffering from obesity will translate to adults suffering from obesity. So what I try to do is, and I don't see a lot of kids, but what I try to do when I go to the community is talking to the mothers and making them understand that culture, that Hispanic culture, that you have to be this, what we call them chubby baby, and then a kid with a fat, that is not adequate. That I don't know when in history that was started in the Hispanic culture, but now we have to stop it. And then that is not the healthy, because that's what we're seeing. The healthy kid is that kid. No, we have to change that paradigm. So this is another question that also we need to address with understanding the culture. Probably other cultures are different, and we cannot address the same question with the problem the Asian culture or the Black African American culture. But at least with the Hispanic culture, we need to address them and make the mothers understand that a healthy kid has nothing to do with the weight, has to do with the style or living style that the patient has.
Yeah, I think that's an excellent point, and we keep coming back to culture, which I think is just such an important consideration. I will say, it's very helpful to know sort of what cultural tradition someone comes from. Not that you should, make presumptions or, predeterminations based on, how you think someone identifies. And certainly, Hispanic culture is not a monolithic thing, just like Black culture is not a monolithic thing. There's definitely, variety, variation, nuance and differences, but as a baseline, that might be something to, raise your attention and say, you come from this tradition. Is it the case that, when you go home, grandma is trying to, fatten up the young one or something like that? I will say from what I saw, practicing in the Bronx, again, with a predominantly Caribbean population, was that, the rates of obesity were so astronomical and had been for so long that sort of the whole normative idea of what body habitus should be had changed, right? And so, people felt if they weren't, of a certain, a certain size and shape, that they were actually too thin and unhealthy, right? And I had patients actually push back on diabetes control and other sort of like metabolic management because they didn't want to lose too much weight. They didn't want to look thin, like they didn't feel that was attractive to sexual partners. They didn't feel like it looked healthy. There was the notion that, this is how people should look now. And in fairness, right, if you look around in the community, that's what 80% of the people look like. So, it becomes not only a complex problem, but, a generational problem, and one that like has sort of a negative reinforcing loop. That's a tricky thing to break.
Certainly. We have time for one more audience question, and it's a very direct and candid question, but I think it's an important one. Is will anyone weigh in as to how much of the obesity disparity problem that we're facing is due to systemic racism?
If you want a number, I would say it's a substantial contributor. From what I can see in my sort of environmental assessments and what I know about sort of industrial or industry advertising practices, I would say it is not trivial.
I agree. I think all the policies and practices that contribute to systemic discrimination, systemic racism, will continue to drive obesity disparities among ethnic groups. And we talked about many of them, different social determinants of health, such as quality of healthcare, education, food insecurity, income, safe housing, and social support. They all play a role. These ethnic groups that we discussed, Black, Hispanic, Latino, American Indian, unfortunately, they're more likely to have, worse quality schools, which leads to lower high school graduation rates, and unfortunately, so less education as a result. Sometimes they'll have individuals or household incomes that are below the poverty level. And so these all result in unequal access to quality schools, good paying job, better neighborhoods, health insurance, and quality healthcare. And this, in turn, contributes to disproportionate growth of health disparities, including obesity disparities in these ethnic groups.
And I want to echo both of you because I think that systemic discrimination and systemic racism has been a big problem in chronic conditions, especially in obesity, from the healthcare system to the social determinant of health to the society at large. We know something that we have not yet mentioned, but we know that employers discriminate. Not just now by race, ethnicity, but because if you are obese, and then they will not hire you. So this is happening, and they think that even in healthcare, I have an experience that one of in the selection of process of our fellowship, we several years ago, there was one of the applicants that have that suffer from obesity, and she was the comment that was made is that, oh, she wants to be an endocrinologist and that's her weight. So imagine in our own healthcare system, we're suffering this. So when I try to put the systemic racism, yes, it's influenced because there has structure immersed in all the structure, but there's also systemic discrimination that is also immersed in all the structures. And to make a change, I always think that we are doing the correct thing right now, but we are going to see the change really 50 years from now. One generation have to pass. And hopefully the next generation, if we continue doing what we're doing right now, will not have to talk about this anymore, because it will not be part of their daily life.
Thank you to all. Last question as we wrap up, and we'll go around alphabetically, maybe by last name. What's one key takeaway, best practice, key insight you'd like to share? We have about 3 minutes left, and we'll start with you, Dr. Lucan. Or Dr. Correa, sorry. We'll start with you, Dr. Correa.
So one key point away of this is, first is important. Listen to your patient, understand the community that you are serving, and understanding means everything on that, all the social determinant of cultural, and always try to advocate at your local area to find ways where you can solve some problems. And if you have that passion, go above that. And then advocate at your city, your county, your state to make changes so all the community can benefit.
Thank you. Dr. Lucan?
Great point. Dr. Correa a little bit stole my thunder. I think I would resonate with all of those comments. But I would say if I had to leave with a parting thought, it might be that, obesity is a multi-component, multifactorial, complex problem. And the solutions to addressing it are not necessarily simple, but they're not necessarily intuitive. And so I think, reflexively as healthcare providers, sort of this mantra of, eat less, move more, eminently unhelpful, personal directed advice that, winds up, oftentimes causing more harm than good, when really, we need to address, very often, not only be thinking outside of the box, but literally working outside of the box, the clinical box, the clinical exam room, and going out into the community. And as Dr. Correa said, advocating for patients, thinking about these ways. We talked about the interface between clinical medicine and public health, thinking about the environment, thinking about, where patients are living their lives and how they're, trying to action on or implement the, good advice that you give them. Just being, consummate, advocates for the patients.
Thank you so much.
Yep.
Dr. Okagu, key takeaway.
Yeah, and I agree with both Dr. Lucan and Dr. Correa. I think the biggest take-home message on how we can begin and continue to address health disparities in the obesity space is to be hyper aware of our own implicit biases that we have about certain groups in our population and work towards counteracting them. So we talked about a few ways to do that today. And one of the major recurring themes was actually listening to the patients and not treating any patient group as a monolith, but taking our time to understand the patient as an individual, doing our best to understand how we can best approach treating that individual patient and not using a one-size-fits-all approach.
Well, thank you so much to everyone today. With that being our last question, we'd like to wrap up today's webinar. Just again, want to thank you, Dr. Correa, Dr. Lucan, and Dr. Okagu for leading today's very engaging discussion. I just want to also thank everyone for joining today's discussion. We hope you found the webinar to be valuable as you and your organization to work towards building a more inclusive and equitable healthcare system. We also want to thank today's partner, Novo Nordisk, for bringing you today's webinar. Our next in-person program is our 10th annual Diversity, Inclusion, and Health Equity Symposium this summer here in Chicago. The symposium is one of the country's leading and longest running events focusing specifically on health equity, health disparities, critical DEI issues in the US. More information will be included in the follow-up post-webinar emails. Again, I just want to thank our esteemed panel and thank you everyone else for attending. Have a wonderful day.
Thanks so much.